Hello, and thank you for joining this OncLive TV peer exchange, a prostate cancer update on clinical practice, biomarkers, and urologic practice management. This program will feature expert perspectives on the use of biomarker testing in the world of prostate cancer. We will also explore novel agents now available for use in patients with castration-resistant prostate cancer. My name is Raoul Concepcion, and I'm the Director of the Advanced Therapeutics Center at Urology Associates in Nashville, Tennessee. Participating today on our distinguished panel are Dr. Ken Kernan. Ken is the Medical Director and Head of Clinical Research at the Michigan Institute of Urology in Detroit, Michigan. Dr. Brian Melhoff, Medical Director at the Oregon Urology Institute in Eugene, Oregon. Dr. Ganesh Palapattu, who is the Chief of Urologic Oncology, Associate Professor of Urology at the University of Michigan in Ann Arbor, Michigan. Dr. Chris Przonka, Director of Research at Associated Medical Professionals in Syracuse, New York. And Dr. Neil Shore, Medical Director, Carolina Urologic Research Center, Atlantic Urology Clinics in Myrtle Beach, South Carolina. Thank you again for joining us today, and let's get started. So, as we move forward, I think what's happening in this entire age, I think prostate cancer, we're a little bit behind some of other tumors like, primarily breast, is this incorporation of biomolecular markers using whether it's next generation gene sequencing, cell cycle proliferation, gene assays, et cetera, et cetera. So, Neil, give us a little breakdown, if you would, because you've published extensively on the general categories, how our viewers need to view biomolecular marker and testing in the world of prostate cancer and diagnosis.
Yeah. So it's an area that's so ripe with so much data now, and virtually every other week we're getting a new marker or a diagnostic. So the first thing I would say is don't scratch your head and walk away saying it's too overwhelming. Follow the literature. Simplistically, maybe three buckets. We're seeing new markers, whether it's tissue, urine, or serum, as to the first bucket, whom to biopsy. Outside of the traditional metric of PSA and DRA, so whom to biopsy. There are markers that are unique now in that space. For our patients who've had a negative biopsy, how do we make a better decision to avoid an unnecessary repeat biopsy? So that would be the second bucket. And then the third bucket would be for the newly diagnosed patients with prostate cancer, what other markers, specifically genomic assays, are now available to us to help us better risk stratify our treatment decisions and ultimately effectively decide upon an interventional versus a non-interventional therapy.
And the fourth bucket, which is probably the more challenging, as we institute therapy, how to monitor that therapeutic intervention and when to change, if to change. So, no, I think that's great. I think, Neil, as you said, we all have partners that they sit there and they're overwhelmed, and we have this broad category of biomolecular testing. And I think to really, as you said, put them in buckets, pigeonhole them, and have really an understanding of what all these individual tests are, what are they measuring, and more importantly, how to clinically use them. So Ganesh, we've started off back in the 70s and 80s in terms of who to biopsy with prostatic acid phosphatase. Then obviously we moved into PSA testing. We've looked at free and total. We've looked at PSA velocity, PSA density. Give us a rundown, if you will, about some of the various tests out there that are adjunctive to PSA testing in terms of who are the appropriate patients that need to get biopsied, especially given the fact that we've had this de-recommendation by the United States Preventive Services Task Force.
Yeah, sure. I think both you and Neil bring up an excellent point. It's helpful, I think, to the practitioner because there's really a cottage industry now of prostate cancer biomarkers. Just really discretize these, and as Neil said, into who to biopsy, and you have a negative biopsy, and then once you have a diagnosis, now what? From a broader perspective, I think the real problem is not diagnosing more cancer, it's diagnosing more aggressive prostate cancer. So if you have that from the outset as your sort of window into the field, I think that really sets the stage. In terms of trying to refine our ability to diagnose more aggressive prostate cancer, I think many of the biomarkers unfortunately fall short. They're perseverating on, to some degree, of finding more prostate cancers. There are some biomarkers, however, that are really trying to make a foray into this area. There are several biomarkers that we're using right now here at the University of Michigan in this particular space. In other words, the folks who are trying to figure out who to biopsy. They include the ones you just mentioned, this PSA and the Sen of PSA, primarily free PSA. We don't use a prostate health index at the University of Michigan. I think it is available in some labs. It requires a special lab. As you know, it includes -2 Pro PSA, which is an isoform of PSA. Not all labs have the ability to do that. Data with that biomarker has shown some benefit for not only diagnosing more prostate cancers, but also aggressive prostate cancers. That is to say, Gleason 7 or higher. PCA3 we also use in this area, recognizing, of course, it was not FDA approved in this space, but rather for once you've had a negative biopsy, it is actually used by many of us to try to determine whether someone needs a biopsy or not. I think over the past few years, we've had a greater recognition that biopsies are not benign. They have side effects and they have impacts on patients' quality of life, et cetera. And so hence, I think the refinement in terms of identifying who needs a biopsy and who doesn't. 4K score is also helpful, which is inclusive of PSA and all the variants of PSA, and H2K, 4K is 4-callicrein score for prostate cancer. Also has some benefit in helping distinguishing aggressive cancers. It's a blood test from non-aggressive cancers as well as just diagnosing cancers in general. And in Michigan, we're also using a test called the urine MIPS score, which is a Michigan prostate score, which is a combination of serum PSA following an attentive DRE. Then you get PCA3 with T2-ERG, the TMPRSS2 gene fusion, ERG fusion in the urine. Putting those together in an algorithm and then trying to come up with a patient's likelihood of having cancer, and then I think really more importantly, the likelihood of having aggressive prostate cancer. I'd say one last thing to keep in mind is that many of these tests have not been validated in large cohorts that include African Americans. And I think for many of us who treat African American men, one has to be cognizant of that, and the biology of this disease may be different in them. And so a lot of these studies need to be verified in other broader populations.
I mean, that, again, that is a great point.